Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care.
Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, host of Pop Health Podcast. In today's episode, I had the privilege of sitting down with Jacey Cooper, who is the former California Medicaid Director and Chief Deputy Director for the California Department of Healthcare Services. In today's episode, we had the opportunity to hear how Jacey Cooper helped lead the California Advancing and Innovating Medi-Cal initiative, which launched officially in 2022. Jacey shares a little bit about the background, including a roadshow where she spent almost an entire year going throughout the state to get feedback and help develop this program while she was initially appointed under Governor Jerry Brown and later under Governor Gavin Newsom. We hope you enjoyed today's episode where we learn about the history of the CalAIM initiative through Jacey's lens, as well as what she thinks of the future of California Advancing and Innovating Medi-Cal. We hope you enjoyed today's episode. Feel free to check out other episodes of Pop Health Podcast by visiting us on our YouTube channel, on our website, or listening to us wherever you listen to your shows. Thanks, everybody. Enjoy today's episode. Jacey, thanks for joining the show today.
Of course. Happy to be here.
Yeah, and happy to have you. Folks, I was telling Jacey before we started the show, I was really impressed. I hope it's okay I share this, Jacey. You were a little bit under the weather recently. And what I loved about Jacey, who, to be upfront, I don't know too well, met briefly in the past, her sense of extreme ownership. So if you folks don't know, there's a book called Extreme Ownership, and it's a phrase used in just leadership circles. Even though Jacey was really under the weather, she told me, hey, if we have to do it this day, I'll still do it. And I just want you folks to know that that happened. And we did move the date because I had some flexibility, but it was just really impressive, Jacey. And again, thank you so much for joining today.
Of course. I think ownership is probably one of the biggest parts of my career, is what I would say. So I'm usually used to showing up whether I feel good or not. And so it was just a very natural reaction.
Awesome. Well, I really appreciate it. So today we like to get started with learning something maybe outside the workplace, a fun fact, hobby, something like that. So can you tell us a fun fact, surprise about yourself?
What I would say is I love traveling. So I've been to 6 of 7 continents. I have Antarctica on the short list of one I would like to get to, so I can check all 7 off. But started traveling really, really young, both across the U.S. as well as internationally, and just love getting out and traveling, seeing people, learning other cultures. And so, yes, it's a huge thing I do outside of work. It's usually the only big factor that gets me out of the office for a little bit. So I try to use it as my downtime and rejuvenation.
Okay, so Antarctica is the last continent. I hear there's some rough water passages you have to go through.
I have too. Yeah, I've been doing my research. That is very true. And so it will be interesting how long it takes me to get there because I get a little seasick. And so, I will do it at some point because I feel like I need to, but I have heard it's a little rough.
Yes, well, that'll be a cool bucket list to check off, and you'll join a short list, I'm sure, of folks who have actually been there. Okay, well, let's talk a little bit about your background before we jump in to some of the work you've done. Mostly, we'll talk about your work in California that you've done in the past, but we'll also talk a little bit outside of that as well. So tell us about your upbringing, your schooling, and eventually how you got into policy, healthcare, all that good stuff.
Sure. So I'll start maybe in college. So I went to USC. Yes, I'm a Trojan, fight on. And when I was at USC, I had the opportunity to go to South Africa with a group of students from across the nation as a part of an Eisenhower Scholarship program. And we went and traveled to learn and understand how South Africa had responded to the HIV in their country. We talked to the university, we talked to community-based organizations, we went to orphanages. The reason why I start here is it is where I really understood the power that government has in regards to response to health, how it can shape health, how it can impact different pieces. And it's how I really lean towards going more on the policy and administrative side. I once thought I wanted to be a doctor. And it just opened my eyes in regards to how important it is to play a role in regards to those types of decisions. I eventually, went into risk management right after that, which was very interesting kind of pivot in life, but made my way back to very early early in my career. It was important though, because it was on the data side of things. So I learned kind of how to do data, an IT system on the risk management side. So it was a very interesting kind of foundation for me there, but moved then to public hospitals. And that is where I spent the beginning of my career, almost 8 years in a public hospital in Kern County, Kern Medical. And did a variety of things there. I ran or helped run their indigent health program called Kern Medical Center Health Plan. So it was a part of originally came in as a project manager under the HCCI work. That was kind of precursor. And then in California, they had something called the Low Income Health Program. So that was the precursor to the ACA. And I ran that program for the county of Kern. Also worked with outpatient clinics, did behavioral health integration. Yes, all the way back at the beginning of behavioral health integration over almost 2 decades ago. Kind of interesting to see how we're still working on behavioral health integration now. But I also did things like started the county's self-funded health insurance plan, or moved them from a county-owned and operated hospital to a hospital authority, passing 2 bills in California. So essentially started as a project manager and left as the vice president of the hospital, and just really loved my time in the delivery system. I learned a lot that I brought with me when I went to the state, including understanding that kind of healthcare, not kind of, just healthcare is a human right. And you kind of live by that mantra in public hospital system. To be honest with you, you care for anyone and everyone who walks through that door. So that has really grounded me through my career significantly, to be honest with you, really shaped my lens in very real ways. And one day I got a call from the state, someone I worked with when I was in the public hospitals who had transitioned to the state. And they said, hey, why don't you come up here and work with us on some policy? And I kind of toyed with it for a while and eventually said, yeah, let's do that. It was a big decision. I moved my family from, Southern California and Bakersfield up to Sacramento. So it needed to be right. And ultimately was appointed by Jerry Brown originally under my first position. And I spent 8 wonderful years at the Department of Healthcare Services, 4 of those, almost 4, being Medicaid director, where I worked on CalAIM and a number of things that I'm sure we'll talk about today. And loved my time at the department, as well. I was appointed by Gavin Newsom as Medicaid director when he came in to that work. And then, building relationships is important. And so one day I also got a call from CMS and they said, hey, how about you come or consider throwing your hat in the ring for 1115. One of the longstanding group directors at CMS who ran 1115 demonstrations was retiring. And I obviously have done a lot of 1115s, both implementing on the ground in my career at a public hospital, multiple, as well as, designing and implementing or amending multiple at the state. And so took that opportunity as well. So it's kind of spanned my 20 years of Medicaid policy experience and operations and shaped kind of where I am today.
Yeah. Wow. That is a really cool journey. A lot of people don't know where Kern County or Bakersfield might be. So folks, that's just north of Los Angeles, probably like 90-minute drive with not much traffic once you get past northern LA there. So you took your family, you went to Sacramento, and I know when you jumped over to CMS, Centers for Medicare and Medicaid, you're spending like a lot of time in DC as well. So you've been all over. You like to travel, and now you're doing your own thing, which we'll get to at the end as you run your own consulting firm. I know you're slammed there as well, which is really cool. Sure. Before we jump into the CalAIM initiative, which I think a lot of our listeners are really eager to hear how you helped build the California Advancing and Innovating Medi-Cal program. We'll talk about the roadshow that you did to get people's buy-in and understanding and just learn yourself to your perspectives now that you're away from the initiative and the results and what you think is to come. So we'll talk a lot about that in the latter half of the show. Before we do that, you mentioned 1115s. Now, I've been in the home care world in my day job for a long time, and I still today, even though I work with a lot of Medi-Cal, have very little true understanding of what that means. Are you able to maybe in as best as possible layman's terms explain what an 1115 waiver is?
Sure. It's very wonky, so I will do my best, is what I will say. So essentially, the short answer is 1115s are a way for states to test innovative ideas in Medicaid. That's the easiest way. It gets kind of very particular. You only use 1115 demonstrations when you're usually testing something, which means you're waiving, that's where the word waiver comes from, waiving some part of federal law that you otherwise want to change, or test a way of doing it differently while those rules are still in place, or you request what's called expenditure authority, essentially for federal funds that otherwise are not allowable in the Medicaid program. So both of those items together are usually why states use 1115. So it's where you can test big delivery system changes, new benefits that aren't otherwise allowed in the Medicaid program. California has used these for a very long time as a part of their program. What I would say is 48 states, DC, and 2 territories have 1115s, and it represents around 37 to 39, depending on the year, percent of federal outlays. So it's a huge part of the Medicaid program. States, there's very few that have none, but most states have an 1115. They all use them differently. Some have almost their entire Medicaid program in them, and then some have just their innovative pieces that they're testing in their 1115s.
Awesome. My IQ is pretty average, so I'm a layperson. I think you did that really well. I know you're trying. So
I was trying not to be too wonky. When you get into expenditure authority and waivers, it gets a little hard.
Yes, which is why we need folks like you to help guide us and lead us. So thank you for explaining that. Let's jump in back to your role when you were the California State Medicaid Director. And for me, it's always funky to say California State Medicaid Director, because in California, everybody knows it as Medi-Cal.
Yes.
Right? So you moved from you built programs and systems and policies in central, I guess Bakersfield, like Southern California, kind of Central California. But you did a lot there.
Central California for sure, but if you're only splitting the state, it's definitely Southern California.
Got it. Thank you. So you were brought up to Sacramento, and you took on many roles and ultimately became the leader there. And part of that, from what I heard from you a couple months ago at a conference in Orange County, California, was this roadshow. And I would love for you to share a little bit about how building the CalAIM initiative, California Advancing Innovating Medi-Cal, included this time on the roadshow. Can you tell us about that?
I can. So it actually started when I was senior advisor to the Medicaid director at the time. And it started with a very simple white paper around care coordination, essentially this concept around Medi-Cal being just really complex to navigate. You get a Medi-Cal card, but little do you know, you're navigating so many different systems. Your managed care plans provide your physical health. Behavioral health is, some services are in the county, some are with the plans, dental separate. If you need regional center services, there's so many complexities to navigating it. So it started with this very simple white paper around how we can think differently. There were pilots going on across the state of California, these whole person care pilots. So the two coming together was really this driver towards let's go out and talk to people. Let's figure out where we need to go. And the Medicaid director at the time said, yeah, that sounds great. And so I set off, myself and Brian Hansen, he and I pretty much toured almost the entire state of California. We went from all ports, the coast, the Northern California, Southern California. We would go for multiple days. We would meet with managed care plans, providers, counties, pretty much anyone who would take our invitation. We usually started every presentation with about a 5-minute, hey, this is what we're doing. And the question that we opened up to them was, what do we need to improve in Medi-Cal? What are the opportunities in Medi-Cal? And then we just sat and listened, to be honest with you. And we told them in advance. And so they usually prepared a variety of people they wanted there or things they wanted to focus on. But we came back with, I think I had probably 100 pages of notes from this tour across the state. And essentially just went and started working with people in the department. What I would say is so many people contributed to what ultimately became CalAIM, everyone from leadership to staff. I would literally usually be in this one conference room, and people would just center in and out throughout, almost an 8-month period of just running data, talking to people, building the proposals, scrapping proposals, rewriting proposals.
Yes.
Worked very closely with the secretary at the time, Mark Galley, who, most secretaries wouldn't dig in, but like we had this huge binder, we had to sit and he went through the whole thing. And we just spent a lot of time building it. So I really stress that so many people contributed to the ideas and pieces within CalAIM. And then ultimately it was released. And then even when it was released, we did a lot of public stakeholdering as well, months and months and months of stakeholdering to try to get it right, or as right as we could at the time with the best information we had and the budget to do it. And ultimately, submitted it to the federal government, and that's when the negotiations started, which were very long negotiations for CalAIM, but very, very worth it in the end, for sure.
Awesome. And so I know with the COVID pandemic, there was also some delays in ultimately getting CalAIM fully launched, but ultimately in 2022 and correct me if I'm wrong, I believe that was the official launch of CalAIM.
Yes, January 1 of 22.
Yes, and I believe you were still in the Medicaid director role at that time.
Yeah. I became Medicaid director in January of 2020. So
thank you.
Started in the work in around 2018, doing roadshow, doing all the building, became Medicaid director in January, right when COVID happened. And yes, we had to ask for a 1-year extension from CMS because of COVID, and kind of paused some things and then eventually picked it back up and ran with it. At least for the 1115 part. There's a lot of CalAIM that's not in the 1115, but the parts that needed that authority, of course, that's when those components were submitted to CMS.
All right, awesome. So 2022 is the launch, and from what I recall, might have been a slow. People are learning about it. They're hesitant. They're trying to figure out how to refer. All those lots of parts of the puzzle here. Yeah. But it finally got up and running. We're in 2025, December 2025 recording. So now there's been a lot of folks who've experienced CalAIM, from providers, from payers, from members, as the plans call them, or Medi-Cal beneficiaries. Yeah. Looking back and now outside, are you able to share with us what were some of the initial challenges that you saw there in 2022 or even beyond with getting buy-in, even though it was active already, or getting utilization, that type of thing? Yeah.
I mean, what I would say is CalAIM is so wide. There's so many parts to it. And I think that's one of the parts that was challenging is enhanced care management and community supports got a lot of the airtime because of how transformational they were. I mean, they were huge lifts of delivery system transformation, providers who were converting their, business practices to meet the expectations of the state. I mean, it just took up an insane amount of time. Managed care plans figuring out what the heck these things are, how they're going to authorize them, how they're going to manage them. There were just endless meetings is what I would say, and conversations. So I think, one of the biggest things is just the complexity. I think in hindsight, and I think I even mentioned this when asked a question in Orange County, was, we were under such pressure to kind of move quickly, especially because of the delay that we had from COVID and people really wanting to transition out of COVID and starting to do something new. That, we literally got the demonstration approved. I think it was like December 26th or something like that, 2021. And we launched January 1, just launched everything live, right? And so we had done so much pre-work before, but I think giving ourselves a little bit more time in hindsight, I think would be one challenge I would just stress, is just like how fast we were moving. And whether the delivery system and managed care plans could really even keep up with the amount of the volume of policy we were dropping, changes that were happening. I think that's a very real reflection, to be honest with you, especially given how complex the work was. I think that's one. I think the other thing is we were doing this statewide. What happens in rural North is very different than Los Angeles. Yes. And so even being able to kind of speak to all of the breadth and depth of the complexities and questions coming in, I think was very real. from that perspective. And that was, I think, some of our biggest challenges, just the speed, the complexity. I think the other thing I would add was we were adding in new types of services, right? So we were bringing community-based organizations to the table, who, maybe had never enrolled as a Medicaid provider, were funded by grants before or other mechanisms, and now they had to meet all of these rules and processes and expectations and negotiate with managed care plans. I mean, I can't underscore the delivery system transformation that took place in those first few years and continues to take place today in regards to that program. I think it will still have another few phases, to be really honest with you, in regards to the work. But it is really transformational work and work a lot of people should be very proud of.
Yeah, that's great. And I appreciate the reflection there and, lessons learned. But while it was difficult, while it's complex, there's also good, right? Good that happens. And so success stories, looking back, is there anything from your lens, maybe one or two things that you're like, here's what a positive outcome was?
Yeah. I mean, I think what it did is it really allowed us to go back to the roots of healthcare. I'll just put it that way, where it's like really thinking about community, breaking down the walls of healthcare and meeting people where they are. Some of the individual, the ACA expanded coverage in Medicaid to adults. However, we had never really changed some of our processes and systems to meet the expectations of some of the most vulnerable and complex adults in our system. For example, people experiencing homelessness. If you wait for somebody to come into a clinic to receive care, the chances are not really going to, most of people experiencing homelessness are not going to do that. Some will, of course. But instead, changing your model and with enhanced care management, being out on the street, meeting people where they are, bringing it to them so that they have a chance of changing the trajectory of their life as well. Is just really critical. And then, some of the community supports and being able to wrap around some of those services. I think what to me it did and is so important is it actually built a continuum of care for somebody experiencing homelessness. During that time, while it's not a part of CalAIM per se, we greatly expanded our street medicine authority in California, made it easier, breaking down the historical barriers that had been in place. ECM moving out into the street. So to me, in recuperative care, look at recuperative care. One of the most impactful pieces of getting someone who used to languish, we had significant data when we did this, showing that someone could sit in an inpatient bed for 6 months because the staff would discharge them. That's a bed that could be used by someone else. And the amount of cost in the healthcare system versus a step down to a recuperative bed, that is way less costly than any inpatient day. I can promise you that. It's just so meaningful. And it allows that time for that connection to build a care plan, maybe to get them into housing, depending on housing availability. So to me, I think that's one of the biggest successes is starting to build. There's still a lot of work to do there, don't get me wrong, but building that continuum of care for people experiencing homelessness is a huge success. I think the other one that doesn't get a lot of airtime is really preparing California for an aging California. So a lot of the things in CalAIM, or not even CalAIM, CalAIM, because you got the duals integration, awesome. You have a lot of the pop health stuff, really important. But even within the community supports and ECM, expanding out, home modifications, wrap services to keep someone safely in their home. Those are things that our community supports that have a long-standing return on investment, significant dollars being saved by them, and built that capacity across the entire state, and will continue to grow that capacity. One of the goals of CalAIM was really to get to true managed long-term services and supports across the state of California, right?
Yes.
And this really helped expand that. And it doesn't get as much attention. People just silo in regards to ECM, community supports, these pieces. But I do think it's one of the pieces, still a lot of work to go there, but a huge outcome and success, or continued success, hopefully, for the CalAIM initiative.
Awesome. I want to touch on the home modification piece because I think there's an example, and you can jump in if I'm off base here. Community supports, well, there's the CalAIM initiative, and there's lots of different things under it. And community supports used to be called in lieu of services.
Oh,
right? And it was changed to community supports. But the reason I bring this up is, what is it in lieu of? So someone who's living in a home in a wheelchair, for example, who
mhm.
can't get around their home, right, may have to be placed in a skilled nursing facility or something where they could get around,
Right.
right? But imagine if they can have their home modified, but they don't have any money for it, so they can't do it. They got to go to SNF. But there's a little bit of money so that they can fit through the different, maybe it's an older home, right, with the narrow passages, things like that, or there's ramps. And there's money for this so that the person can remain at their own home, like you said, at a much lower cost. And they're much happier because they're in the community, they're at home versus a skilled nursing facility. So is that a right example
That's
of?
a great example.
Okay.
And yes, in lieu of, because it was a very wonky term that everyone was like, what is that? So we renamed it. But yeah, it's in lieu of something more expensive, an inpatient
Yeah.
stay, a skilled nursing facility stay, emergency room visit, or some larger treatment, that by providing this intervention, you would ultimately reduce costs and see better outcomes. When people stay in their home with wrap services, home modifications, higher quality of life, longer, better health outcomes, significant financial savings that had been demonstrated for decades in this space. And so, yes, that is a great example of a very wonky in lieu of services, but also known as community supports in California. So,
Yes. Very good. So you might see that in the history books, that little ILOS acronym, but we're really trying to keep it as community supports. Okay. So after your time as a state Medicaid director, you mentioned the opportunity at Centers for Medicare and Medicaid Services, or CMS. Tell us a little bit about your role there and what your experience in California, how that was able to help in that role.
I mean, I think a lot of things helped my career broadly. I think having delivery system experience was critical. It was critical for my work at the state because I had run care management programs when I was in the public hospital example that shaped my thinking. But I brought a lot of the experience I had from California to that work. I think I have like 8, 11, 15 demonstration, either new submissions, implementing, or amendments in my career. So I came to this work with a lot of experience. I usually, which is probably not the case for all states, but I love to be in the middle of the negotiations of 1115s in California. I don't know if my previous team in state directed state demonstrations group always loved that when I was Medicaid director, but I loved being in it, right? And so I came to the work at CMS with really good foundational on the policy side and operations side too. I mean, when you run a program as the size of California's Medicaid program, you get exposure to both. And I joke, in California, you have almost one of everything, and they're usually the most complex version of that.
Yes.
And so I came in with that kind of solid framework. And what it let me do is, lean into both. 1115s are extremely political. Typically, and they're usually pretty sensitive and usually complex policy.
Yes.
But coming from a state like California, where that's kind of the world we live in, for me, that was a very kind of normal environment to be in. And so I loved doing the work. And policy-wise, we were able to do things. For example, Arizona was the first state to request traditional healthcare practices for tribal partners. And it was done in originally requested, I think, in 2015. California came in 2016.
Okay.
We had been trying Arizona and California forever to get that thing approved. And there was just a number of barriers in the way, very real ones from the federal perspective. But when I was able to get in there and work closely with the CMS team, and we had a great team in our state demonstrations group who were very passionate about this. They really wanted to see this thing cross the finish line. In fact, I'll give them shout outs. Kate and Kelsey did an amazing job on this particular work, but just really worked through a policy that had been sitting for a decade, states waiting for almost a decade, and got that across the finish line. And really, I think it comes from having the state experience, but understanding the federal landscape, what the parameters were, and ultimately got 4 states approval for traditional healthcare practices in that time. It's just an example of where my experience from the state crossed over with real alignment with multiple states trying to do something in a very meaningful way, which was really great. And then my operational experience also really helped as well. State demonstrations group, because of COVID and so many people needing 1115 COVID demonstrations,
Yes.
they had built up some pretty significant backlog. And the pressure was coming down. When governors submit a proposal to the federal government to innovate their Medicaid program and it sits for 2 years, it can get a little spicy, to tell you the least. And so
Yes.
we worked really hard to, the whole team, process improvement, break down that backlog. We did some innovative things in regards to how 1115s are processed to get reentry demonstrations out the door for the justice work in that space. So really brought both policy and operations to my role at CMS, and enjoyed every minute of my time there with that team at CMS, to be honest with you.
Yeah, awesome. Well, thank you for breaking that down and how your work mostly in in California helped you have an impact across the country and other states, things like that. But you're not doing that anymore.
No.
You're doing a couple things. Before we jump into like your day to day, I don't know if your role at Berkeley is day to day, but I know you're doing some things at Berkeley. Tell us about that.
Sure. I'm an impact fellow for UC Berkeley School of Public Health. So through that, we work with students, faculty, and others, and we pick a project. And my project is actually focused on reducing administrative burden, and working with a group of around 5 graduate students to kind of really just wrap our arms around, okay, what are the biggest drivers of administrative burden in healthcare, but really focusing on Medicaid, not necessarily just California, but Medicaid as a whole. We're also looking at the intersection of not just where there's administrative burden, because there's plenty of that in healthcare for the record, but where there's a direct intersection with outcomes. And if you reduce that burden or remove that burden in some substantial way, that there's a direct correlation to outcomes being improved. And so we're doing a lot of research right now. We're doing interviews with subject matter experts across the nation, really to inform, there's so much happening in AI, there's so much happening in technology, there's so much happening in regards to focusing on admin burden. But if we could drive people to not just the stuff that saves the bottom line for plans and providers, which is important too, because we need providers to have efficiencies to join and be Medicaid or Medi-Cal providers. So that's important. Yes. But we also want there to be a focus on looking at the admin burden that improves outcomes for people. And so that is what we're doing with my Impact Fellowship at Berkeley.
Quick question on that. Are you still looking for folks to give feedback and be a participant? Or are you already?
100%. Yes.
Okay.
I did a blast on LinkedIn. Anyone can reach out to me if you want to be a SME interview. We're doing those in early January. So links are going out now to get people signed up for those interviews. Yes.
I thought I saw something like that. Yeah. I actually put a feeler out with an organization that I think might be a good fit. So I'll let you know.
That'd be great.
If they can help. That's great. Okay. So really quickly, before we jump into what you're doing today outside of Berkeley, but kind of your organization that you're leading, you mentioned administrative burden, and I want to give you kudos as again, I have a day job that does fall under CalAIM, and it's really great to see DHCS and the plans not just say it, but I think they're actually I've seen action where they've removed some administrative burden, which is really cool. But I also know it's difficult. It's a finesse, right? Because there's a reason certain policies and procedures are in place, right? Yes. There's a reason. So removing that, does it create a gap? Does it create, an opening for trouble or things like that? And that's hard. That's a really hard finesse job. So the students that you're leading at Berkeley, this is a really difficult task, I would say. Challenging for sure. But man, I'm excited for the results. And I've seen results of your leadership in California. So really cool. Just want to give a shout out to you, JC, and your students for working on that.
Thank you. Yeah, we're looking forward to it.
Awesome. Cool. And again, folks, look up JC on LinkedIn if you have work for an organization that could potentially contribute to the work that they're doing. She put up a post on that. Okay. Lastly, as we wrap up today's, there's 2 things. What are you doing today outside of your role at Berkeley?
So I did launch my own consulting firm, and I've been blessed to be wrapping around a lot of things really quickly, which is great. I'm working on a lot of things in that space, whether it's affordability, which is really important to me, both the admin burden part as well as just broadly affordability in healthcare, huge important piece. I'm working on what's next on the horizon for Medicaid financing. HR1 really just shaking things up in Medicaid. And so we need to find what is that next step in regards to how to stabilize Medicaid programs. Working on protecting coverage, really important that everyone who needs to have Medicaid or Medi-Cal in California remains covered. And so spending a lot of my time there. We're helping states respond to HR1. All states are being hit differently, but most states are being hit in one way, shape, or form. So helping them navigate that. And then dabbling in some stuff that I've always enjoyed, children's health and maternity health. They're huge passions of mine. Something I didn't mention on this, but I was lucky enough to have Medi-Cal when I had my twin girls. They were covered under Medi-Cal. And so it's just really important to me that we improve children's health services and maternity services for all of Medicaid. So that's how I'm spending a little bit of my time these days, is what I would say. Yeah.
Yeah. Well, I love the mention there about your personal life, how your family and was on Medi-Cal yourselves. So you've had personal experience as a user, right? Not just a leader of the service. So that's really cool. I think the biggest thing for us as we leave today's show, and I think our audience will be very interested in your thoughts, is the waivers, the CalAIM initiative. What do you think as we look at results and outcomes and try to figure out, results ultimately? What do you think the future is of what's currently available under CalAIM?
I mean, CalAIM is so expansive, so it's kind of hard to pinpoint one. What I think the lasting legacy of CalAIM will be is the department taking a population health management approach. So really looking at different populations and what are the services and supports that population needs to essentially improve outcomes and to kind of move the space. I think that's how I think about ECM, community supports, and all the other pieces, because it falls into how are you improving various different populations, using data to inform that, and driving towards informed decisions in the delivery system. So I think, to me, I hope that is the living legacy and future of CalAIM, because that means that it lives on. It's more of a mindset now. It's about removing barriers to care and health, and really, to me, it represents kind of going back and remembering that, health is not just about treatment. It's about, healing and living. And I really live by that. And I think that's what CalAIM represents. It's, again, I know I said this earlier, but it's breaking down those walls of healthcare in real ways. And even if some things change in the future, I think that is a true mindset that people have realized the impact and importance of that in health and outcomes for people. And I think that will live on forever.
All right, Jacey. Well, thank you again for joining the show today. And I think our audience is really going to appreciate learning from you and just the history. And folks, again, look up Jacey on LinkedIn, JaceyCooper, for those of you that are just listening, and see if she can, if your experience can benefit her group in Berkeley. Jacey, thanks for joining the show today.
Yep. Thank you.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.